The patient that I chose for my case presentation isn't one of the infants that were at our facility. Because of the nature of the facility, there were not many infants. He was between 4 and 6 months old. He's an African American male born to a single mother with an active maternal grandmother. His primary concern or presenting problem was premature birth. He was born at about 28 weeks gestation and has therefore been hospitalized since birth due to his extensive medical concerns. Upon clinical evaluation, the concern was for his feeding. He did have some issues with weight gain while in the NICU. They played around with that for a little while. It seems to be resolved. He does present with nasopharyngeal reflux and GERD. He has a G-tube placement per the NICU because of his feeding issues, and he has a recent test that came back positive for MRSA. His medical history, like I said, is very extensive. The majority of the individuals, actually all of the individuals in this facility, are on some form of mechanical ventilation. He is on mechanical ventilation due to chronic respiratory failure that was brought on from his premature birth. He has bronchopulmonary dysplasia. And of course, with premature birth, there is low birth weight. And like I said before, he does suffer from severe gastroesophageal reflux disease, and that actually interferes with his feeding. His social history is pretty limited to our knowledge. Like I said, he was born to a single mother. He does have really good family support though. His mother and maternal grandmother are very active in patient care. They're there very frequently, which is not seen a lot with a lot of the younger patients because they do live there full time. The focal problem for speech-language pathology was in regards to feeding. He was not able to do PO feeds due to his nasopharyngeal reflux. He did have an established suckle and was able to elicit feeding but could not maintain without nasopharyngeal reflux. He does also have some delays or deficits in his language and social skills. He doesn't play very much, but he is, but it's primarily due to the fact that he's been hospitalized since birth, so he doesn't have those experiences that a lot of infants have. So we kind of refer to his adjusted age for those things at the moment. His treatment plan was primarily for PO feeds. We did a lot of modifying of his environment. For instance, we changed his positioning. Instead of cuddling him like an infant while feeding him, holding him at an angle, he was sat upright during all feedings and remained upright for 20 minutes after feedings. The bottle had to be changed a little bit. He required a slow flow nipple, more specifically one that would only do single drips at a time, which is hard to find with multiple uses. They eventually changed it to a specialty bottle called the Haberman bottle, which is what they're currently using. They also changed the feeding style that was required. So instead of just letting him eat at his own rate, we did have to slow him down a little bit. The SOP would allow 3 to 4 suckles per, before taking a break. So letting him get 3 to 4 suckles from the bottle and then removing the bottle from his mouth entirely to kind of slow him down and determine some volume control. And a lot of this came about through different trials, starting with his positioning and then his changing the nipple for the bottle and the bottle style. A lot of trials for him. His outcomes so far have been he's made some progress. He originally came to us in PO on a G-tube, of course. He experienced moderate to severe nasopharyngeal reflux with almost all PO feedings. And for quite some time he was only allowed to be fed by the SLP or his family, which included his mother or grandmother, and he would only accept a half to 1 ounce per feeding. He fatigued rather quickly, usually after about a half an ounce. Currently, he is PO. He's being fed on a regular schedule. He experiences minimal to no reflux through his nose, and he is able to be fed by nursing and family. The SLP primarily feeds for monitoring now. He will accept 2 to 3 ounces per feed, which is almost his entire bottle. I think they do give him another ounce or so through his G-tube still. And he fatigues a little later, but a lot of that could be due to the style of feed, because he does need some volume control when he's eating. So he's made some progress, and he will hopefully continue to make progress. I learned a lot from this particular case. I definitely learned that I am very interested in infant feeding. Along with this case, there were 2 others that involved a lot of feeding skills, I guess. For this particular patient, it was the first infant that came in that I was able to participate in the evaluations. So I learned a lot about informal evaluations for infants, including for his feeding skills and his language skills. I got to see that for the first time. I also learned a lot about the different factors and compensatory strategies for feeding, especially with this little guy. He required a lot of compensatory strategies for his reflux. He needed to be repositioned. He needed to be, his feedings needed to be changed entirely in order for him to be able to eat by mouth, which is a big thing for these little guys. There is one thing that I would have liked to have done differently. I would have liked to have done a modified with him. While I did get to do a modified with a 1.5-year-old, I did not get to experience a true infant modified. We did not do one because the NICU had administered one about 3 days before he was transferred to us. So the SLP used that report to kind of limit his exposure to the modified. He did not experience any aspiration through that, but it would have been helpful for me, I think, to see that. And I think in future cases I'll be able to look back and think on this particular situation and kind of think through the different factors that I need to look at when feeding an infant, different things that I can try to maintain PO feeds with infants.